surgery or if you do not have any stents, then you have to start thinking about biologic with the distance apart and stuff like that. So let's do some mathematics, guys. This tooth here is tooth 2, 3. We want to place the first implant on this side over here. Okay, so what is the distance? So let's say your implant is 4 millimeter diameter, right? So that's the first reading, 4 mm diameter. How close must the implant body be away from the adjacent tooth? What do we say? At least 1.5. At least 1.5. Okay. When you do your first round drill, what is the distance from the round drill to the side of the tooth? 3.5. So the average is about 3.5 to 4, between 3 to 4, okay? Because you can't measure this 1.5, right? The implant is not there yet. You can only measure this dot here. So this dot, because it's half, 2, so it's about 3.5 to 4. 3.5 to 4, you make your first dot, first round burr, okay? If you are putting a second implant, what is the distance from this to this?
Diameter of the second implant is
Same, let's say regular 4.
7.
What is it?
7.
This is 2. This is 2. In between 3. In between 3. 1.5 plus 1.5. Yeah, 1.5 plus 1.5, 3. 2 plus 3 plus 2, 7. So first implant to the second implant, 7. Remember, we have not put the implant in yet. We have not done any drilling yet. Just one round burr. Okay? 7. This is now 2.4. Now you want to put on a 2.6. This is 2.5. 2.6. How do you measure? From here to go there. Another 7. So what does this mean? This means that for our exercise, you find the first dot, which is about 3.5 to 4 from the adjacent teeth. From here to here, 14. 14, 15, plus minus. You increase to 15, you increase to 16 when? When this is a wide diameter body implant, then you increase the space a little bit. Get it now? If you are doing 2 regular implant, 7 plus 7. Can you see how with the knowledge that you learn, the hidden message, you do this, no guide. That is your initial point that you do first. So what I usually do, sometimes if they sell it here in Yangon, they call it the indelible pencil, those surgical pencils. So you can just make a dot there and then move it around. Does it make sense? Okay, so let's do this today, right now. And we on the motor. And do we have a new 15 blade? 15s, new 15s. I need one more. Oh, we don't have a barrel prober. We don't have a barrel probe here, guys. How do we measure? We can use a ruler, the metal one. You can autoclave that. Yeah, the metal ruler. What I'm going to use is this. This is my ruler. Yeah.
going to start helping out with the prosthetic sides on both the 1.4 that you place and on the bridge 2.4 and 2.6 that you place, okay? So make sure that you place your implants correctly, because otherwise the prosthetic management will be very difficult. Okay, so this is what we want to do. We look at the situation, we pretend that this is a real patient. So I would like to have some feedback, okay, just shout out and let me know what needs to be done first. So what do we look for at 2.14 position? What are the few things in a real life patient that you look out for? Keratinized gingiva, yes. We want to see whether there's enough keratinized gingiva, because let's say, according to the picture here, is it quite clear? If the keratinized gingiva is not enough, then basically what I want to do is a slightly off mid-crestal, like a little U shape here. Okay? And obviously before that, you want to take an X-ray to check, or a CBCT to see whether there's enough bone on the buccal. Because if there's not enough bone, what do we need to do during implant placement? GBR. And then if we need to do GBR, what does that mean? That means the implant will have a short healing abutment or a cover screw, correct? Yeah, things like that. It has to run in your head, you know. So you can't open up and then you like, okay, I didn't order the implant, I forgot. Then you close it back up, or you call Mr. Charlie to come. Okay? The other thing that you want to check in your X-ray is to make sure that the alignment of the adjacent teeth. So the adjacent teeth would be 1.3 and 1.5. They need to be parallel, yes? Because if they are not, then that's where the BLT works. Or you need to make sure that you align yourself. Make sure that you don't touch the adjacent teeth. So we go ahead first with the preparation, okay, with your 15C blade. I like this as compared to the 15, because the 15 is too large for me. So the 15C blade looks like that. Is it clear? Yes. Tell me if the image is not clear, then I need to move. So let's say the patient has not so good keratinized gingiva. So we come in and then we do a mid-crestal but a little U shape. Can you see how I do it? Yeah, just a bit of a tiny U. Okay? I do it again. Okay? And if this case doesn't need GBR, then it's going to be very simple. So we do what we call intrasulcular. Okay? Into the pero pockets. We do intrasulcular on the palatal. We do intrasulcular on the buccal. We do intrasulcular on the palatal and buccal of the adjacent teeth. Okay so far? Yeah? Then we use this kind of instrument, what we call a flap or a periosteal elevator. Can you see that? Like a little spoon. So it has a fat one or a thin one. My preference is always to start with the thin one first, okay? To be gentle. You have to respect the tissue, especially with thin biotype, aesthetic zone, high lip line, things like that. So you use the instrument and then you go in and then you start wiggling a little bit, okay? If you find that, oh, the incision is not good enough, don't force with this. So you go in with your 15C again, make sure, and you get a very clean cut. Okay? Again with the periosteal elevator, you go in all the way down to bone. All the way down to bone, just like your wisdom tooth surgery, and then you kind of raise it slowly. Can you see that? It's good. And then slowly you raise this. Sometimes in the molar side, where the soft tissue is so fat and it's so thick, then that's when I start using the bigger side. Okay? And then I just slowly, again, the trick is go down to bone. You have to go down to bone. That's the trick for oral surgery. And then you push, and then you push. Okay? Thank you. And then you check, how is the bone? Not bad, right? So I think I can do without GBR. Okay, now my next question is, if the bone is not great, and you're going to get a dehiscence. Then you think, okay, I need to do GBR. So what do I do sometimes if the flap is too tight? I drop a vertical release. Okay? There's two ways to drop a vertical release. I just drop one vertical release to make things easy for you. So you can either drop one on the canine over here, or you drop one on the premolar over here. What do you think I would do? Who says premolar? 1, 2, 3, 4. Who says canine? So it's quite almost the same. Actually, I would drop more on the premolar. You know why? Aesthetic side. If the patient is very demanding, high lip line, thin biotype, you get a scar sometimes here. But whether is it right or wrong, there's no right or wrong. Both works. But if you are so, now everything, you are so skilled right now, and then you want to fine tune your surgery, I just do it on the backside. But if, let's say the patient's mouth is so tight, he can't open, then do you want to drop one on the vertical? It's very difficult, to suture, to put the bone there. Then you drop on the canine, right? So it depends. You play by ear. For this case, you don't need. So Miss Odeta, we can actually. Okay. So you look at this. If you have a stent, you have a surgical stent. You put it inside. Okay, and that little tooth there has a gingival margin, right? We talk about it. So we want to make sure that. Okay, look at it. Does this case have recession or not? Okay. Is the bone irregular? If it's flat, what do I do the first drill? If it's very irregular. Straight handpiece, round burr, slow speed, you prepare the implant bed. You make it smooth. A little bit. You don't have to do the whole thing. Just a little bit. Now let's pretend that it's flat right now. Okay. We start doing the implant drilling. So you have this really nice motor here, okay? And what's the first drill? Round what? Round 1. So the round 1 is 1.4, okay? So this is how it looks like. Make sure that you have all the irrigation. This is my motor here. For this particular exercise, I'm running it at 1,500 because the bone is really very dense, okay? No water. Okay? If you follow Professor Boozer's traffic light rule, okay, everything has to be in the middle, in a traffic light green zone. So we actually choose the middle side here. So lots of irrigation, you go in, everything is flat, and then you start making the first point. Okay? Okay? And then remember what I told you about the drill? The round burr, what can you use it for? Two purposes is to mark your first drill, and then you check. Secondly is to check how dense the bone is. So sometimes I go in a little bit deeper and I'm like, wow, after going in at 2 millimeters, it's still so dense. And then you know that, okay, this case is about type 1, type 2. Okay? After round 1, what do you do? Round 2, thank you. So round 2 is something that if you want to make some changes, you make right now. If you want to push it more palatally, then what you do is that you put it in and then you pull it towards you. Okay? You have to change that. This is the way that you want to change the direction. If you want to move it more mesially, then you have to go in and then you have to move it more mesially. Okay? Likewise. Okay? So if I like the position over here, I just go ahead and prepare this. Obviously, you use the irrigation. You don't use your mouth to blow. That's not very hygienic. Unless it's a girl. Okay, round 2. What's the diameter of round 2? 2.3. Is 2.3 to fit the? Exactly. So you have the 2.2 drill. Okay? People ask me, do I use the short drill or do I use the long drill? For, what do you think? Sorry? Short drill or long drill? Actually, to me, the short drill is more controllable for people who are not so experienced. You know why? Because when it's too long, it's like fighting. The long one is not so accurate. The short one, you know. So if you want to kill someone, you use a short knife, not the long one. That's what I mean. So, but I'm just going to show you with the long one. But if you're not sure yet, you try with the short drill and then followed by the long. Okay, so you check. Is it in a good position, guys? Yeah, not so bad. The way to do implant drilling is not to go in one time, is to go in and out to let the irrigation to go in. Can you see that? In and out. In and out. Okay? You have the marking, the black marking there in the meantime, and then you see. Implant I'm going to place is about 10 millimeters. In my personal experience, okay, you should drill at least 10 millimeters. But sometimes what you want to do is go down a little bit deeper. Maybe 10.5 or 11. Why? To give me the flexibility. Let's say if I want to place the implant deeper, I can do that. But of course, you have to check first. No sinus, floor, no nerve. Make sure that you have enough bone. If you have like 14 millimeters of bone, then you can do it. Because if you were to prepare 11 millimeters, and if you want to hide the implant, let's say, because you check the gingival margin or the crown and you want to measure 3 millimeters, you can put it deeper. Because if you prepare 10 and finally when you want to put an implant and you want to put it deeper, you are stuck and then you have to remove the whole implant and drill again, right? So it gives you a little bit of flexibility. These are tricks. Okay? So I drilled down to about 10 and a half. Okay? What is the next step, guys? Can you move? What is the next step, guys? Not yet. You want to what? Yes, you want to check. The tapered guide pin looks like that. Can you use a normal bone level guide pin?
Not yet.
No, right? Doesn't make sense, right? Because the bone level, the normal one, is too fat at the bottom. Now I have another silly question for you. Can the bone level tapered guide pin fit inside your normal bone level side?
I think so.
Yeah. Right? Okay? So you go in and then you check. The guide pin does two purposes. Okay? What does it do, guys? First, it checks your depth. Are you in the correct depth? Okay? This is very tight. See how tight this is. So I'm in the correct depth. I'm 10 millimeters. So, sorry, Odetta, can you guys see? Is it okay?
Yeah.
Or do I need to move? Okay, yeah, you see that? Yeah. Okay. So sometimes when you drill a little bit deeper, you can put it deeper. So that's why, if you have that flexibility, it's nice.
Oh, it's too tight. I just wanted to show the number.
The number.
It's okay.
Can you see the number?
No, because it's on the other side.
Oh, okay.
But it's okay because that's the marking.
When you start becoming young guns, number one, Straumann implant user, and you use so much, right? What do you need to do? Sometimes these markings disappear, no? So what do? You buy the pen and then you write your number? No, of course you have to change, just like the drills. What is the recommended usage,
For
Mr.
the
On?
drills is 10 times.
10 times? 20 times?
10 times.
It depends. If it doesn't serve you and it doesn't cut properly, by right, but the manufacturer say 10 times.
Yes.
Okay, the manufacturer say 10 times. Well, I don't use 10 times. Okay. Obviously, you can't use 100 times, right? Then you are a dumb guy, right? It's like giving you the blunt knife and you want to kill someone. It's not so effective. Right? Okay.
Sometimes you can show with this pin the direction as well.
From the
Because,
top, Yeah.
Also the prosthetic platform.
You saw the top, huh? So sometimes you can. This is actually the 2.8 guide pin, but the purpose is the other side, huh? You see? Yeah, you saw in the video, right? I show you. Because you can see the diameter of that little round donut there. That roughly tells you whether you are in the middle. You are, not too distal or not too mesial. Okay, next drill. What is next, guys?
You want the short?
I think I do the short, but I do with the round 3, right? The third round burr first. This one I give you. This one I give you. I have the third round burr.
Okay.
What is the diameter of the third round burr, guys? 3.1. Yes. What is the diameter of your next yellow drill? 2.8. Right? Remember I told you? The round burr is just to open up the top. So you go in. Okay. You check. Do you need to make any more adjustments? Because you still got a chance. Huh? Okay. One more chance here. So you go in. One more time. Okay. I want you to have an experience of both the short and the long drill, and you realize that the short drill is actually very easy to control, as the reasons why I tell you. So I'm going to show you now the short one. Again, we are going down to 10, maybe 10 and a half. So you want to maintain the distance, the direction. If this is the direction that you want, you do it. Oh, one last thing. What if you do not have a guide and you want to check the direction and angulation? You use Dr. Yo's tip, right? For the maxilla, when you want to aim your implant, it has to be on the functional cusp of the lower, which is your buccal cusp. So you put the guide pin and you ask the patient half close. If you like it, that's it. If you don't like it, you shift, okay? Okay, now this is very important for those early users of implant dentistry who have no experience drilling before. When you drill, it has to go in and out, okay? The finger rest is very important, no? So don't do it in the air. The finger rests have to be this way, okay? I stress again, the finger has to go this way, up and down, one direction. Because a lot of the times my students also make this mistake. They go up and down. What is the problem with this? There's an arch, you know. Huh? So your implant is, the preparation side, the osteotomy side is actually an arch. So you really have to go up and down. That's why sometimes the short drill helps, you know, because otherwise too long, you know, you have to have really long fingers or go up. Okay? So you really need to know that, you know, you're not doing this. You know, it's not the wrist. Huh? Okay? It's not the wrist. You really have to control. So up and down, okay? What next, guys? So you want to check the guide. So angulation, guide pin, okay? So this is the next drill. Sorry, the next size, guide pin, the 2.8. So you go inside. Am I getting the readings out? Is it correct?
Yes. Now you can show.
So now I'm going to show you. Can you see that?
Now you can, yes.
Yeah? Nice, right?
Here.
Buccolingual looks good. Mesial-distal looks great. So I think we are in a good situation. Yeah? Okay. So next drill, we have the final drill. If this is going to be your final drill, final implant, the red color one. Alright, guys? Final drill, make no mistake, go into the direction that you want. Lots of irrigation, in and out. Okay. Okay, do you see that? Do you like it? Not too bad, huh? Okay, and then you check with your guide pin. Okay, can you see that? Alright, I'm going to have a short little pause here and I'm going to ask you, what's next right now? Do we put it in the implant? Who says yes? Because you're so excited to earn that 1,800 USD. Oh, I got to put it in. What? Profile, huh? Profile, okay? Profile drill. So you look in your kit. Finish the red color one, you go up. This is your BLT all the way to the right, that whole row, okay? So you use the BLT profile drill. Okay? The other way to recognize is only the BLT has this marking.
Maybe I can just show you because when you read here, you have the legend.
Yes.
BLT.
So as I say again, sometimes it's not your problem, it's your nurse, and if they don't clean properly and they give you the wrong one, okay, so it's your responsibility before you drill. You have to check, no? Huh? Okay? So this is a short profile drill. So guys, I go in, maintain the direction, everything, and make sure. By right, in a human, you use this at what RPM? Okay, so far? And then you check. What kind of bone is this guy? This guy is 1. This guy, for this model, is really 1. So we want a bone tap all the way. And what is the bone tap speed, guys? 15, anywhere from 15 to 25. Okay, same as the placement of your implant. You have to go slow.
Do it with Russia, that will help you.
So I can show you both with, we can show both, right? So I'm going to show you both. You can do the preparation now, either the manual or with the handpiece. Okay.
We have to load.
If it's for the handpiece, it's like that. It's for manual, it comes in like that. Right? As what you saw in the video. Can you see that, guys? Huh? So it's all about preference, okay? So my preference now is by using the handpiece, okay? There's no right, no wrong.
Lower the speed up to 15.
So maybe we lower the speed to 25.
Or it has a problem. Yeah.
Yes.
Does it have a problem?
25.
250 or
No,
Two-
no,
you mean the
25.
dashboard?
The RPM. 25. Can it go down? 25.
25.
25
25.
RPM.
No zeros.
Yeah.
I think it can only go down to 20 or 30.
Okay.
Okay, that's fine. 20. Yeah, 30 is fine. 30 because it's very tough. Okay. In a real life patient, with the drilling of your pilot drills and your twist drills, you roughly know whether this case is type 1 or type 4. Type 3 and 4, maybe you don't tap at all. Type 1 and 2, you have to. Okay. For this exercise, this model is very tight. It has to be type 1. You have to go down all the way. So this is what you do. Go in. Can you see? It's not running at a very high speed.
How about you do it like this?
Okay, come. So you hold it for me.
Yeah.
Can you see that, guys? Yeah? Slow and steady.
Where's the gain?
I can't see.
Now reverse.
Is it
Now
there?
reverse, yeah.
Am I done?
Yeah.
I can't see. Okay. Reverse. Can we reverse?
How many recordings?
Okay. That's it. What else next? We did the bone tap. We did the profile drill. Now it's time to place in the money guy. Now, before I do that, I want to show you. Can I have the profile drill again? The bone level profile drill.
One level or one level?
BLT profile drill. Okay. Just now when I did this bone level profile, okay, I was doing it short. Okay. Sometimes when you have recession, like gum disease cases, or when you're doing it in the front, the incisors, right? The incisors are so long. Then what happens is that my handpiece head will get stuck there. So that's when the long one comes handy. Okay? You understand, right?
Because of the adjacent.
Because of the adjacent, you get stuck there. Yeah. But I know in Europe, they actually came out with this extension device. They even have a extension to the long one, right? For really those receding teeth or those Caucasians in the front, the teeth are so long that you can't even reach with the longest one. You have the extension device. Okay, so now we put in the implant. Can I have the, yeah, because inside must be completely empty. Can you blow that a bit more? Okay. So you open this, untwist this, okay? If it's an XL active, it has a lot of this saline liquid inside, so be careful. Don't do it the other way because everything is just going to drop. So you do it like that, and I always do it over a stir-out tray. Don't do it on over the floor or on someone's head or something like that. Because if it drops, that's it. Mr. Charlie will not give you another one. Okay, so this is it. Then what do? You get this inside. You click it in. Okay, you just turn. You gotta hear a click, just like Lego. Click. And then what I usually do for my personal preference, I use my fingernail and I push it up. Can you see that again? Yeah. So inside. Okay, and I push it up. Okay, and for precaution, what I do is that I now bring it over to my patient, right? Because I do it over the table, right? And I never do this. Because if you do this and it drops, then that's your problem. Okay? So I try to do this. Okay? And over the patient, make sure that my assistant, okay, is all ready, and then I start putting it inside. Alright? Okay. Make sure this is counterclockwise.
Reverse.
Yeah, okay. Okay, you go in. Oh, can you hear the sound? Can you hear the sound? That's very tight, no? Because of this model. Some type 1 bone sounds like that, no? Huh? Can you see that? That's not good, no? Huh?
I smell it. What is it? I smell. What is it?
Okay, let me remove. Remember in the video you have to use like a key or a thing, then you pull it out. But this one it doesn't, okay?
Can I show it like this? Can I show it? I just want to show. Okay.
Let's put it in. Huh? Can you see this? I think I can afford to go a little bit deeper. Okay, but is the dotted lines correct? Yes, it is. You hear the sound just now. For you at the back, you can hear. So for this model, sometimes you have to tap 2 times. Okay, some patients are this very, very tight, the bone quality, type 1. You really have to tap. Because you hear this sound in the patient, the bone is going to die around your implant and you're going to get necrosis. Okay, so let me try to go down deeper. So I'll show you a different technique now. You use the hand ratchet and it works the same thing. Okay, make sure that your marker here is clockwise. This is counterclockwise. So I'm going to move it the other way. This is what we call the holding key or a stabilizing key, and then we, yeah, very tight. Huh? Can you see the dotted line? Is it there?
Not yet. Because you need to go a bit deeper. And go a little bit. Here.
Okay. Yeah? Nice? Huh? So at this stage, you should be, wow, yay, very happy right now. Huh? So, okay. So previously, what we had to do is that we had to put the holding key here and then remove it. Now we don't. Straumann came out with this lock sim device. Because you jiggle, 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 and it will come out, okay? If you are afraid, because it's type 4 bone, if you are afraid, because it's type 4 bone, I repeat, and you jiggle, jiggle, the whole implant comes out. So what you do is that you can use the same thing, okay? You can put it there, and then you jiggle out, and then only the fixture mount comes out, and the implant stays inside, if you are afraid, because your bone is so soft, because sometimes you pull it out, the whole implant comes out. It happens to me before. Okay, so now great. We have the nice implant placed inside, and obviously you have to decide what you want to do. Because if it's just a normal healing, no GBR, I would choose the tallest healing abutment, right? And do it as one stage. Okay, so can I have the healing abutment? So the healing abutment comes in 3 heights, 2 millimeters, 4 millimeters, and 6. I choose the 6 if there's a lot of recession and if my implant is very, very deep. I choose 6. If it's medium, it's usually 2 to 4. Okay? This is what you call the Scs screwdriver. Okay? And it fits inside. Okay? Alright, Odetta, thanks. Okay? And what I do is that I put it inside here and I start twisting. Now, inside the mouth is not easy. So I will give you a trick. If you have a tweezer, not this straight tweezer, the one with the 45 degrees, then like this tweezer, then what I do is that I just hold this like that and I turn. Because sometimes if you are like that and then the whole thing just comes out and then the healing abutment just goes inside the patient's throat. So you got to be careful. So you want to stabilize it and make sure that it catches the internal connection. Finger tighten. Okay, that's it. Can I show? How is it? Looks nice? Yeah, not bad, huh? So we can start closing. So you see, when you close this, the abutment is high enough to stick it out. You don't even need to make any incision for the next round. If you are the restorative dentist, remove it and then you just insert, which is the second half, the impression coping and the other stuff, right? Very simple. So let's go ahead and practice the suturing technique. What kind of sutures do you like best? What kind of sutures do you use if you do surgery? Sorry? Any brand? Vicro? Yeah. What about you? Anyone use silk here? You use silk?
We are informed that using silk is now out of date, is it?
It's out of date. They call it too braided. It tears more and it traps a lot of plaque too much. And of course silk is non-resolvable, so you have to come in. Okay? Because some patients just don't like you to remove stitches. So I choose a lot of Vicro right now or the monofilament. Yeah. Charlie, what do you have here? What brand do you have?
Actually, I'm not really familiar with this.
So you want to, so you just check for
Monofilament.
monofilament, suture, very easy, very clean. It doesn't matter whether you use resolvable or non-resolvable. Actually, they both work. Okay, but what you want is a clean, suture. This is Decalon, monofilament nylon. These are not resolvable, so you have to remove it again, which is okay. But if you feel the nylon, it's not very soft. Some patients don't like that. You know why? You leave the thread too out and it starts cutting and you get ulcers in the mouth. So you gotta, play around and see. Okay? But I will not use silk anymore. Right? So it's either nylon or Vicro. Alright? So we go ahead with the sutures. In periodontology, when I was a student, they taught me so many 100 techniques. But I learned from experience right now, the simpler, the easier. Just keep it very simple because you really want to finish the surgery very fast. Okay? So you get your tweezer. Okay? So after you make sure that you irrigate everything already, and then you get your tweezer, and then you just... My suggestion is just do simple interrupted suture. Can you see that so far? 1, 2 turns. Yeah? Okay, sometimes you get your assistant to hold it there, depends. On top of the thread, yeah. Counterclockwise. Okay. Sometimes if the tissue is just too thick or you are scared that it bursts, clockwise one more time and then that's it. Okay. If this is nylon, you either do very short or very long. Because if it's very long, it will just stay flat. Okay. So I will leave it very long. Okay. If it's nylon, because it really cuts and you get ulcers there. How is it? Simple? Not bad, huh? So very easy. Okay, so I want you to start. Can we start practicing now? Charlie, what's the plan?
Maybe.
Do you want them to practice now, or we go for a quick lunch and when we come back? Huh? We come back from lunch and then we'll start with the practice. I think we do that. Okay. Quadrant. Okay, 2-4 and 2-6 position. Okay. So 2 implants, 3-unit bridge. So this is the K9. This is the 2-3. Okay, are we ready for the second exercise? Same thing, mid cresto, right? If not enough mucosa, we go a little bit palatal. Yeah, so let's do that right now. Okay, so far guys, what's next? Periosteal elevator, we have a few, if you see in front of yours. We choose a small one first. Okay, so you just want to loosen up a little bit at the edge. Okay, you want to loosen up at the edge here. Okay, and then slowly you start raising. Huh? If you find that the small one is too weak, you get a bigger side. And then go down to bone. Huh? Go down to bone. Is it okay? Charlie? Can I have somebody to hold someone or yourself to hold the jaw because it moves around? Okay. Can we see? Alright. What is next, ladies and gentlemen? What is next right now? Yeah? What do we do now? Prepare the bait. Okay, we get a straight hand base, round burr, go in and smoothen up the top. Okay? Then after that, what do? We start preparing the two dots. Okay? So let's begin right now.
Should I hold this one down?
Which one? Yes. Okay, we do the front one first. Okay, first round burr. What do we need to measure? How far away from the adjacent teeth, guys? 3.5 to 4. Huh? 3.5 to 4. So let's say 4. I'm just estimating because we don't have a peroprobe here. Okay, I think this is about 4. Diagnostic T. It's the first one. Which side is this? Yes, okay. This is the diagnostic T. It also acts as your gauge. Can you see the words? Can you see the picture over here? The picture states, okay, I show you a bit closer. Can you see this picture here?
No, it's not.
No.
Okay.
Okay, like that. This picture here means the distance from the center of the implant to the adjacent teeth. Okay? Can you see that? So for the narrow, this is the distance. For regular, this is the distance. For wide, this is the distance. This is what I mean. Huh? So what you do is that you put it like that. Okay? This is like the little ruler. Thanks, on. Okay, because I'm a bit awkward. Okay. Okay, that's it. Let's blow that. Okay, so we got that. It's about 4, maybe about 5 millimeters. Then you go in. Okay, then what's next? If you're putting 2 implants side by side, what is the distance from point to point? If it's 2 implants side by side, 7. 7. So you get the pero probe and then you put 7. Okay? For this exercise, you're doing it a 3-unit bridge, so it's 14. So on estimate, I'm just estimating, because if I have a pero probe or a metal ruler, then this is 10, 12, 14 here. Okay, for example. Okay, can you see that? Are you able to see the 2 holes? One hole here and one hole there. Is it 14? Okay, I can go in a little bit different. Okay, so I'm going to start preparing it with my second round burr. Am I correct? Second round burr, we do it here. And then I'm going to go a little bit more distal because it's not really 14. Something like that. Where is that pump?
Này, nhịp cái nó nhịp.
Can we see that? Is it clear enough? Your side here, maybe. Yep. That's the first one. And that's the second one. Okay? So we now need to start making the preparation. Now this is the tricky part. If it's 1 implant, it's very easy. You keep it in the middle. Now it's multiple implants. You have to make them what? Parallel. Because they are all like that. It doesn't make sense. Yeah? So you check, make sure, follow if you have a surgical guide, you follow. If not, you follow my rule. Implant goes to the functional cast. Okay? On 10 millimeters, right? Okay, perfect. So what we do first is like that. And then you put the first drill, okay? Can you see that? All right. So I'm gonna move this so that you have a nice view how it looks like, okay? More or less. Now I'm gonna ask you a question. Do I continue on this to open up to the next size or what? You want to go to the next drill or what do you guys think? Sometimes you can go and open up this drill and make everything really nice, okay? But that means that you are very sure with this implant position, you know. A lot of things can change. The adjacent teeth could be tilted like that, you know, the mouth could be tilted and stuff like that. So sometimes what I do to teach my students is that I actually try to go in on the other side. Can you see? And then I start making the preparation as parallel as possible. And then all of a sudden, my kids, I was like, oh my gosh, my kids only has one guide pin. So how? Do I call Mr. Charlie to give me a second guide pin? Or what do I do? Huh? Use the drill, thank you. So is there a short drill? There's only one. One. Oh, we have another one. Oh, that's the drill. Sorry, actually this is not supposed to be the drill. This is supposed to be this. Sorry. Then you use the short drill. Okay? Use the short drill. And then you check the implant. Because from here, you have the final two implants and then you use, is it parallel? Yes. But is it in a good direction? Because the adjacent teeth are tilted, so you have to follow the tilt. Because if the tilt is not good here, then you make the change here. Now you see how, when you have two, it makes a difference. Huh? When you have one, you can't really see. You know? Huh? So sometimes I like to do this. I like to do both and see the initial drill. Because I need to tilt, I start to tilt. Because the problem is that at the 2-4 side, if you finish it with the final implant and then you find out that it's in the wrong position, that's it. No chance. Okay? So from here, you can still make the change. You can, let's say if you don't like the tilt, you can still move it like that a little bit at this time here. Okay, so for this exercise, I like the position and everything like that. Okay, so this is what I do. Huh? When I like the position, I actually start removing one of the guide pin and put the second one in, and then I follow this correct guide pin position. You understand what I'm saying? Okay, so this is what I do. So you use the second round burr and then you follow the angulation and direction. Okay? Now at this stage you do the drilling of the second one. It's okay. And then you start. Keep the position ready. Make sure you have to look three-dimensional. So every time when you do this, you have to look buccolingual, correct? Mesiodistal, correct? Try not to go in too fast. Okay. And then you put the guide pin in. Now, when you are at this stage, you have to decide, okay, do you want to continue with this implant on the 2-4 side? If your position on this one is correct, then yes. If your position is not correct and this is a new position, then you have to do it like one at a time, A and B, okay? Very important, okay? So let's say if I like that, then I'll just continue with my drills. Okay, final drill. Let's go in, check. Yes, I'm at 10 millimeters. And then you check, you have to check. So there's two ways to check. Mesiodistal, are they parallel? Yes. And then you have to check. Buccolingual, are they parallel? Yes. Yeah? Okay? Not bad? So this is it, huh? Bless you. At this stage, you stop, and then what do? You go back to this and you start on the yellow drills. Does it make sense so far? Yeah? So multiple implants are not easy, let me tell you this. Because once you get the angulation right, it's very, very easy. But once you get the angulation wrong, it's going to be very difficult now, the prosthetic way. Okay. So you check, you like it, yes, that's good. Next drill. Okay, good. Not enough guide pins, what do? Borrow the short drill and then you check. Yep. Nice. Occlusal buccolingual, good. Mesial distal, good. Okay? Then now you do the final preparation, which is what? The last two. Go up the BLT, red color line, and then you choose the bone tab and the profile drill. Okay?
Reduce the speed.
We can reduce a bit. Maybe you put it at 500.
500.
Okay? Always be focused, because at this time, some of my students, they thought the implant preparation is finished already, and then they go in a different direction. So continue to keep it in a straight direction, angulation and everything like that. Have I? A bit more. Okay, I've not gone down to depth for the second implant. Let's put this inside. I think there might be debris inside.
nênทำหมดเวลา
Can you blow a bit more inside? Okay. Better, right? Yeah. Okay, let's go back to the front. And then we do this. Okay, ladies and gentlemen, I want you to see this. You look at this. If I were to bring this up a little bit, I can make my osteotomy site a bit better. Can you lift up the palatal flap down? Okay. Can you hold this for me? Okay. Can you see this? This is not so flat. It starts going up a little bit. So sometimes the implant might not be, correctly in the same angulation. See? And then one side, the bone is a little bit too high. And then when you put the healing abutment, it might get stuck. Okay, so before you do that, that's why in the beginning you have to be very sure. What you do again at this stage, straight handpiece, round burr, and then you flatten that. Okay, you flatten here. Here, this ridge. Okay, you want to make it a little bit flatter so that the implant goes down a little bit more. Okay, can we do that? Alright. But for this exercise, I think we are almost ready. And now I'm going down to placing the bone tab. So can we have it adjusted to 30? Okay, back to normal again. Okay, reverse. Okay, can you blow it inside? blow it inside. Thank you. Reverse, forward, sorry. Ladies and gentlemen, did you notice that I'm always going A to B, huh? Because at this stage, even though I have done so many implants, I can make mistake with angulation, you know? Okay? Reverse. So always be very careful and do A to B, A to B. You know, it's always never wrong to be extra careful. Okay? So now we are ready. Can we blow inside? So what do we do now? We can place in the implants. And just like how the drilling preparation, how we do the implants, I still have my guide pin there on one of the hole, because I will be basing on that. Okay? Never be too complacent, meaning never to be, oh, I'm so good with everything, now everything is done. Never. So we're going to put the implant right now. So is it forward? And where are my implants? Over here. Same thing, we open this up, break it. Okay. Implant go in. Fingernail, rock, push it up. Okay. Hold it like this, bring it over the patient's mouth. Okay. So we place our first implant, 30 newtons. Go in. Keeping the angulation, the direction and the positioning. Okay? Alright? Because this is locks in, you take it out very easy. Okay? But the dots are not correct. So I'm going to do it manually. So manual placement over here. Okay, clockwise, still my guide pin there, guiding me on my first implant placement. Okay, now, do I remove it like that and prepare the second side? What do you think? That means I take this out and then we put in the second implant? No. You know why? I'm putting back the fixture mount. That is my guide pin. Huh? Right?
It becomes your guide pin.
It becomes the guide pin, you know. Wow, this Dr. Yo is so smart, huh? I will teach you something else. Huh?
I think this is...
Can you blow one more time?
过来的.
Okay, rock, fingernail, push out. Yes? Forward. Okay, everything goes in. Okay, the polka dots are not there. Can you hold this for me? This one.
No, this one.
Okay. Alright, hand instruments go in and then you put in the implant. Voila. Yes? How does it look on this side? Yeah, not too bad, huh? Okay, so this is the trick, multiple implants. You have to do this, you know, you have no choice. 2 implants like that, how are you going to do the bridge? Everything customized, and once you do that, it's going to raise the lab costs. Huh? Keep things very simple for you. Okay, then you place in the 2 healing abutments and then you close, like how I do that, okay? I'm going to teach you one more trick. Let's say you did implant on the first one, and then you want to do the second implant next to it, but the bone quality is really bad, and then you try, not good, the guide pin is like moving. Don't do the implant. GBR, close it up. Okay? And then the front tooth, if you wish, don't restore yet. I mean, this is one option. Huh? If the patient wants the tooth, then okay, maybe you put a temporary crown. If the patient is okay, then what you do is that you bury everything. You wait 3 to 4 to 5 months, you open up again. Don't throw your fixture mount. Keep this, because when you come back again, you open up the flap, you remove the healing abutment, you put this as your guide pin for the first one, and then you follow. Does it make sense? Okay? So you keep this, you know? Okay? Because this will be sometimes future guide pin for you on some cases. So usually I have about 5 to 10, I autoclave it and just put it aside, just in case if I need to use it. Right? Does it make sense? Because if you will restore that with a permanent crown, and then now, oh dear, what direction is it? Huh? Right? Okay? So, Odetta, what do I use to cover this up? I think we don't really need it, because from here we can take over and do the prosthetic side already.
Sure, but
Huh?
in case they want to close it, it's up to
Oh, yeah,
them.
yeah.
In case.
Okay. Do the participants have sufficient
Yeah.
healing abutments? Okay. Okay, so good. Can we have the retractor again? Okay. My Scs screwdriver. So I'm just going to close it up so that you guys can practice suturing. Second one. Okay. Now I'm going to give you some tricks on suturing for such a long thing. Huh? Okay, so what I usually do is that what kind of suture that Dr. Yo likes? Simple one, interrupted. Okay, so I start one here and one here. Okay, and then after that in between. Because sometimes some of my students, and in the beginning of my career, I start here, and then after that everything is pulled and I got nothing left. Then I have to remove, and I have to start all over. You know, it's like when you want to fix your two curtains. If you keep on fixing like that, the curtain you keep on pulling, and then this side you have not enough cloth. So you start on this side and you start on this side, and then you work in the middle. Okay, does it make sense? Okay, shall we practice? The two exercises, we have all of us here, we're going to help you in terms of recognizing the drills and instruments, okay? And then you have enough sutures to